Thank you very much. Thank you, Shara. I'd like to first thank UCLA. This is the third series of talks that I've given for UCLA, and it's really a privilege. We have this opportunity to talk to not only the UCLA community, the Los Angeles community, and at large, because now with technology, this goes out to the World Wide Web, and it's really great. And the purpose for any of these talks is really to empower patients with education. I think that's the key, because really talking about evidence-based and why at UCLA. So the title of my talk is Platelet-Rich Plasma in Facial Plastic Surgery, Facial Rejuvenation, and Hair Restoration. So I'll give you a little brief history about myself. I'm an associate professor and the residency program director in the Department of Head and Neck Surgery. And specifically in our department, we have a division of facial plastic and reconstructive surgery. And the reason that's divided is that we deal with both aesthetic, cosmetic issues as well as reconstructive issues. But the real important part about that is I think they're one and the same. When you do reconstruction, when you do aesthetics, there's form, function, beauty, all those things are together. We want things to be as near perfect as they were before and after, and try to improve that. Before I go into the actual talk, I do want to talk about one thing that's really important to me is patients always think, well, at UCLA, we don't do aesthetics and we don't do cosmetic surgery. A lot of times I hear that, and even some family and friends say that. And I said, no, actually we do. We have a lot of people that focus on aesthetics and cosmetics, but then what makes UCLA different? And I think what makes us different in some ways are two reasons are the main thing. The first one is sometimes we may be the end of the line, meaning you've had a procedure done and you come to us for a second opinion, or you've seen others, experts, and we're here to kind of really state of the art. This has become complicated. We need to revise things. That's one scenario, and that goes to our expertise. So we have a lot of experts, and it's not just facial plastic surgery. I really want to commend and also include the entire aesthetic family at UCLA, and that involves the division of plastic surgery and dealing with everything from the face down to the feet, body, everywhere. We have our cosmetic dermatologist as well as our oculoplastic surgeons, and they're all excellent. And one thing that makes our expertise critical is that we're board certified. So for example, in our division, I'm board certified in otolaryngology, head and neck surgery, commonly known as ear, nose, and throat. And then I'm also board certified in facial plastic and reconstructive surgery. Why is that important? I think for patients out there, you really need to make sure that you empower yourself and educate yourself, but also your surgeon is truly certified by the board to practice that expertise, in addition to what they're doing, what's the latest and greatest that they're doing. So those are the two things. Really make sure your credentials and I think those are the main reasons at UCLA we offer that level of expertise. I have no disclosures. A lot of the things I'm going to talk about today. So the goal today is platelet-rich plasma. Introducing the concept. Many people probably in this audience already know about it. They've heard about it. They may know about it from orthopedic surgery. So my goal here is myself, as well as the UCLA approach, is evidence-based. What does that mean? Unfortunately, we're going to be a little bit behind the times sometimes when it comes to aesthetics. And what I mean by that is our surgical skills are top-notch and ahead of the game. I get that. But when it comes to the latest and greatest that you may hear about, platelet-rich plasma was one of those 7 years ago. It was used in orthopedic surgery. It was used in facial plastic surgery, plastic surgery. Some of my mentors used it. I'm a little bit later on coming on board. Why is that? Well, I think oftentimes the litmus test and what we want to do is to make sure the evidence is there. Patients are happy. The results are there. How long does it last? Does it really work? And the goal today is to give you an evidence-based approach, not to bore you with the science of it, but really to kind of educate you on the things we're doing, and the way I approach platelet-rich plasma is based on the evidence. What's been shown by the literature, people studying it and publishing it, and how we can apply it systematically. We don't just take the latest new filler and just try it. We want to make sure it's been tested and it works. So the goals today are to kind of demystify what works for platelet-rich plasma, what might work, and what really doesn't work as of yet, based on the evidence. I'd like to first introduce, without jumping into platelet-rich plasma and saying PRP, again, we need to know what are platelets. Let's think about just wound healing. When you cut yourself, you start to bleed. And some of us may be on an aspirin or something, we bleed a little bit longer, but eventually we clot. And then a few days later, we look back and where we cut ourselves, it's pretty well healed. We still see the scar. A month goes by, it's less. 6 months go by, it's gone. And sometimes the scars stay there. So what happens? Well, let's go to that first response, the injury. Our bodies are amazing and we kind of take it for granted, a simple cut. That bleeding that stops, the first response are the platelets. We know that because when we take medicines that stop our platelets, we bleed a little bit longer. Our healing takes a little bit longer. So people started studying what's in those platelets. We've known this for a long time, but in those platelets are growth factors, things that stimulate growth, healing, new tissue, letting us heal. The scar doesn't open up again. We can go and do our activities. If you've had surgery, your incisions heal. Platelets play a critical role, but we kind of take it for granted. But the reason I put this slide on is it kind of just gives you a little bit of the science. It has these little terminologies, PDGF, that's platelet-derived growth factor, transforming growth factor, fibroblast growth factor, all these growth factors. But there's inflammation and there's healing. Why I'm bringing this up is as we go into hair later, how we're going to respond to hair and grow hair potentially with our own platelets, we don't want too much inflammation. Because if it's inflamed, the hair follicles are sensitive. So how do we kind of get the good parts of our platelets for growth, eliminate the inflammation as much as we can, and try to capitalize on the healing? So that's where we're kind of the background, okay? And the idea of the term platelet-rich plasma, I'll definitely bring it up and go over it again, but the goal is, again, take your normal platelets and make them rich, more. Increase the number. That's the goal. So where has it been used? So as a filler, if you will, to fill certain areas. Face, breast, gynecologic, urologic, skin rejuvenation, and we'll talk about that today. Hair restoration, which is another focus today. And then a little bit, we won't really get into it too much, but I'll touch on it. Wound healing, skin graft healing, and maybe we can combine it with fat transfers. Oftentimes we do fat grafts to reshape our face with fat, and maybe we can help that with platelets. And also just if you do a literature search, if you Google, for example, you'll know that you'll realize they use it in joints, stem cells out of platelets. It works in certain parts of the body. And so the goal today is focusing on the face. This is just another introductory on those growth factors, and it kind of tells you what they do. So we know that these are all in our platelets. Cell growth, production of new blood vessels, collagen. Collagen's the material, the proteins that we need to actually have good skin. As we age, our collagen gets less, our skin gets loose, we get these fine lines, and it shows the signs of aging. Let me digress for 1 second. People say, well, Dr. Nabili, your background, what did you do? What kind of surgeries did you do? So I've been at this about 10 years now. And so the first about 6 to 7 years, my focus was on reconstruction, big operations, transplanting tissues from different parts of the body to reconstruct the face. I'm on the face transplant team. We're on the verge of doing our first total face transplant on the West Coast. These are really involved operations, but now you're going to talk about platelet-rich plasma. You do facelifts, cosmetic surgery, you do eyelid surgery, nasal rhinoplasty, but why are you talking about things that are not surgical? And the important things on that is because in all the surgeries we do, there's this misnomer. I have patients more often than not come in and they say, Dr. Nabili, I get it, my face, we can do this, my neckline I don't like, but the reality of it is my skin quality, these fine little lines around my mouth, I don't want to put a filler in them. I have lines around my face, around my eyes, we call these crepey lines, very fine lines. You can stretch the face till eternity. You will not get rid of those fine lines. We can't improve the texture. If you have an old scar on your face, if you have acne scars, it's nearly impossible with just trying to pull tissues to get rid of that fine contour texture of the skin. So that's why I was open to ideas on how to improve that part. We lift the face, but I'm looking at the face. Patients agree, I agree. Those little subtle things, I get it. Surgery won't help that. We need something else. What else can we do that's not involved? And also, what about patients who don't need surgery or don't want surgery? It's too involved. Let's rejuvenate. So getting back to the platelets, this is just more of a stepwise approach where what's happening with the platelets and what the thoughts are currently. So really that area where you form a clot, platelets come together, there's been trauma. The trauma is the key point. Some kind of insult has to have happened for our platelets to get active. Even a needle stick or a tiny little poke on our skin will cause a little bit of blood. We know platelets go there because we eventually stop bleeding. I shaved this morning, I may have a little bit of bleeding, it stops. Platelets were there, growth factors were there, and we're going to focus on it now in terms of aesthetic rejuvenation. I think the obvious benefit of PRP, which I think is great, is it's part of you. We're not doing anything to your platelets, and I'll describe all of that. We're not adding anything to it. Sometimes we may consider adding something to it, but my philosophy on this is keep it simple, keep it clean, keep it part of you. Minimize the risks, focus on just your body. It's your own body. You shouldn't have a reaction to your own platelets. It came out of you, and it's going to go back into you, concentrated. So they shouldn't have a reaction to it. Why is that important? Sometimes fillers have risk, very rare. I put fillers all the time in patients. It is very safe, but it does have a risk. It's not part of you. It's formulated. Botox, potentially there's a risk, but we do it all the time. It can improve wound healing, which is what we want. So if we're going to do surgery sometimes, or if someone's thinking, I'm losing a lot of hair, I'm going to get a hair transplant. Well, lo and behold, a lot of the hair transplant doctors and some of the experts at UCLA are adding PRP. They're doing the transplants, they're doing the facelifts, and maybe they're adding the PRP on top to improve the healing. The term augment tissue is adding filler, bolstering the tissue. Angiogenesis means improving blood flow, because if we have good blood flow, we heal. Adipocytes are fat cells, and keratinocytes are skin cells, rejuvenating them as well, increasing their growth. So how do we do this? Back to the steps. So if you want to get PRP therapy, I urge you to educate yourself through the internet, because many patients do. You'll see the steps, but I put some slides, and all the references are there for every slide that I took from the science that's in the evidence presented. So we collect your blood. We have you get hydrated. I tell patients drink a lot of fluids that day so we can have good access to your blood flow. It's one needle stick. We draw the blood. We spin it through a machine, and it separates the blood cells from the platelets. But then among the platelets, so the top of the tube is more and more translucent, transparent. The red part of our red blood cells are removed. Why? Because the red blood cells, together with the platelets, when you cut yourself, activate your platelets. They work together, and they bring it all together with inflammation and healing. We want to separate and get the platelets to do their job for healing and lessen the inflammation. And within that translucent part, we have platelet-poor plasma and platelet-rich plasma. And I'll tell you why this is important as we get further on. So there's different approaches, and I'll tell you why I chose the method we use. Again, I have no disclosure as to why I choose this company over another one, but I'll tell you why I choose a one-spin technique, but there's different methods. And the one spin, two spin, I bring this up because, again, when you leave today, you're going to not only be educated on what are platelets, what's platelet-rich plasma, but when you go see a doctor, whoever it is, you're going to know, well, Dr. Nabili did mention there's different variations, and now I understand that you're doing this version, and I get why. And maybe I want to ask more about that version, and I think I'm going to try that version. So one spin, two spin, and then this other topic called platelet-rich fibrin matrix. That's adding something to the platelets. And we'll talk about why that's important and some of the data out there. So the one spin technique, I won't get too involved in it, but really we're separating the blood. One spin means you put it in the machine, it spins, it separates. In the two spin technique, you take the top part that's cleared, spin it again, and separate it even further, get more of the red cells out of the way, get more of the platelets to separate into lower and higher concentrations. The one spin, less blood, because remember, the more we spin it, the more we're going to dilute. We want, if you get one blood draw, much better for patients. I prefer one stick, minimal pain. We sometimes put topical numbing medicine, just like we do on children who get a blood stick, because I want it to be a painless experience. Less blood, minimal bruising, and that's the one spin technique. The It's effective as a filler, and we'll talk about that. And the term HA, if you see that anywhere, it's hyaluronic acid. It's a part of us. But when it's concentrated and made by companies as a filler, that's what HA is. Sometimes you'll read and you'll get confused, and I want to demystify that part too. Has anyone may have heard the term vampire lift? That's a trademark. It's proprietary. A physician created that concept. I think it's amazing. I think it's great. But that's specifically to someone who's trademarked, and that's exactly what is known to that physician. And surgeons who do the vampire lift need to be certified and trained by them. But I bring that up because it's a misnomer that's been carried through all PRP. People think what we're doing is now this vampire. This is not a vampire lift. The idea was removing blood and then you're placing it back. The concept of removing blood was the idea of a vampire lift. But that's where fillers come in. And when they talked about a vampire lift, the idea was that you're actually adding fillers with the PRP to really give a maximal rejuvenation of someone's face. Elevate, improve the texture and contour, combination. It works great. But you need to do your investigations on that. Make sure you find the person who's trained in it and is certified by the people who train them, by the physicians who do the vampire lift. But that's a separate thing. So useful for under the eyelids, and we'll talk about that as well. Hair growth, that's our goal today. If anyone's had laser resurfacing, we're now using PRP to improve our healing. The goal is when we do lasers, a lot of time there's downtime. It may take a week. With really more modern techniques and lasers, the downtime is less, a few days. And so adding something that would help healing, PRP helps. And then what I do, which is skin rejuvenation with microneedling, and I'll go into what that is very shortly. So two-spin technique, I'll just go really quickly through it. I already touched upon it. Greater amount of blood needed. You get a higher concentration of platelets because you're spinning it twice. It just takes more time, and it may take more blood, and I think making it simple may be better. Orthopedic applications, they need a lot more for joints and wounds, so it's more often used in that area, in that subset of the population. And then finally, this matrix idea, which I encourage you to also, you'll see this terminology. You'll say, well, this doctor uses PRP, but they're adding, I see this term fibrin matrix. Now you know, well, what is that? That's activating it. So it's making your platelets that are liquid, once you draw your blood, more gelatinous because you're partially activating it. And the theory behind that is not only will it go in and become more like a gel, fill the areas, but it may last longer and dissipate longer. My thoughts on that will be a little bit different, and I'll tell you why I don't do it, because I feel like if you activate it before it's actually in you, I may lose some of the benefits of the platelets. I want it to be pure, going inside your body, let your body activate it and really be maximal. Because I don't want to lose any of that platelet growth factors that we talked about earlier. I don't want to lose any of it. If we're really taking it to give it back to you, try to get the most out of it. But there's nothing wrong with this method. It works great, and there's papers that I'll talk about that show it works. So I use the Eclipse system. Why? The tubes there are almost life-size, if you will, but on the screen they look quite large. But the original tubes were much smaller. You draw your blood, it's a simple 10 to 11 cc tube. And you remember, we're going to spin it. So even though we took 11 cc's of blood, by the time we get the platelets out, it's less than that. And then among that, we still have low concentration, high concentration, that's less. So that may involve more blood from you, more sticks. So this company came out with a concept of having not only a larger tube, but separating it into a higher concentration. Why is that? Well, here's where the tides turn now, and this is where I focus on. If there is platelet-rich plasma out there, and we know it works, and I'm going to show you the data, why not give the highest concentration that I can for you if my goal is to give you the maximum amount of healing? So that's why I use the high concentration now. All of it. I just use high concentration for hair restoration as well as high concentration for rejuvenation, and we'll talk about that. So our system, simple, safe, I'll tell you why. One spin, one tube, high concentration. Now let's get into what works. These three areas, the data will show you and the evidence will show you that it works. I believe in it. The areas that might work, I'm open to. We'll wait and see. If it gets better, I'll go into offering that as well. So let's talk about what works. Facial resurfacing, skin rejuvenation, PRP alone. Again, simple, safe. I'm only going to use PRP, not going to add anything to it. With microneedling or with laser, and we'll talk about that, and the data will show that. For hair, so the idea that, wow, your platelets can restore hair. When we get on the topic of hair restoration, I will tell you, it's not the holy grail. It's not going to make you grow lots of hair, but it will improve hair, and we'll show pictures of that. But it's really caught on in the past 2 years, with the data showing 2 years out some really positive results. And there's some conflicting studies, and I think that the evidence will show, and the protocol that we use at UCLA will try to minimize poor results. And then using the PRP with or without a filler. The data works in that favor as well. So let's look at the evidence for skin rejuvenation. I'll just briefly go on this because I think this is a little bit too much of the science, but it's there. The thoughts as how it works. Really what we're trying to do is improve the texture, the contour of the skin. Not pulling the skin, not trying to fill the skin. This is a really important concept because if you go to someone who's putting PRP for a filler, I don't think you'll be happy because it's short lasting. It may last a week, it may last 48 hours because it dissipates. Those growth factors disappear to the microscopic level. The effects start kicking in 4 weeks, 6 weeks, 12 weeks, 6 months to improve the synthesis of all the age-related changes that have happened in your skin, and we'll show you photos of that. I bring that up because when you see how it's done, you think, oh, this is like a filler, or it's like getting Botox. Approach-wise, maybe. The needles are small, very small, similar to what we do for Botox, similar to what we do with fillers, but it's not a filler. We do it throughout the face, neck. I don't focus below the clavicle, but our plastic surgery colleagues do, as well as our dermatologists. But you can do it in age-related changes on the chest, skin tissues, arms, legs. This is just PRP alone, not as a filler many months out, 3 months to be exact. It's improved, so then someone looks at this and says, wow, they got filler. What do? They didn't get filler. So if you actually improve the elasticity of the skin will be more strengthened, the turgor will be there, it'll be more rejuvenated, but it's not going to eliminate things. But if you look around the hollowing around the eyes, so if we look right here, the nasojugal folds are less apparent, and some of these multiple lines in texture and contour get improved. It's not a filler, and the nasolabial folds did improve, but it wasn't because it acted like a filler. So let's look at the evidence. So this paper looked at purely skin texture and tone. 23 patients. They used a dermoscope, which is this fabulous microscope camera that gets really focused. And you look at giving just PRP and do those fine lines improve over time. Not overnight, not right when you leave the doctor's office. Well, maybe when you leave the doctor's office, because it actually did fill up the area. But in 72 hours, it may decompress, lines come back, but you wait and you'll see it improve. Scars. So I do a lot of reconstruction for dermatology. So if someone comes to me with a skin cancer that's been removed and they have a scar there, or I've done their reconstructions. If we wait 9 to 12 months, it will improve, but oftentimes that's a long time to wait. So doing PRP, and I'm going to show you something else that I add to it, microneedling, improves scars. Acne scars. PRP alone, I think PRP alone is great for these. I don't think it's enough. I think you need to look at the science on how everything works with injury and do something with PRP. What is that something? Remember, if you have some injury, it works better. You activate more platelets. And we'll talk about how we're going to do that with this next slide. Okay, this slide's important in the following way. Concept. So let's look at aging. Okay, so this is a diagram kind of showing our skin from the outside. The first layer is the epidermis and all the way down. And these are the collagen fibers. Youthful, you can see the number of collagen and fibroblasts and all the things that are there are increased. As we age, things drop, but the reality of it is things get weaker. You lose collagen. And so this is what happens with aging. So the concept would be, can we pour something through the top going down? Just simplistically trying to demonstrate. If we make tiny holes or injury and we pour some goods in there, some growth factors, will it improve the skin? It's been damaged, right? So we want to get platelets in there. We also want to damage the surface, because if we damage the surface, it will try to rejuvenate and heal, and hopefully as it heals, it will try to revive and get better, and those platelets have come there, the blood flow's gotten there. So my philosophy is, why don't you do two things? Damage the surface, damage from below, but as you're damaging both levels, you're filling it with growth factors. So this slide shows whether we do lasers, which many people know, but some people don't know about microneedling. So microneedling may come in a roller. So you may go to a plastic surgeon who uses a roller. Great, works fine. Microneedling could be a pen. It could be something of a bigger device that has radio frequency attached to it. The concept's the same. Tiny needles that penetrate the skin, and they cause damage to the surface. If you did it alone, you'll heal. If you did PRP alone in the earlier slide for the acne scars, you'll heal. But what if we combine all together? Damage from above, inject the PRP from below, even pour extra PRP through the surface of the skin at the end to let it go through the pores. We'll talk about that as well. But the concept makes sense. We've already thought about, well, now we're activating more and more of those high concentration platelets to get the best response. Microneedling, let me just briefly talk about that. So I think you can actually, you'll go to estheticians and you'll see that maybe there's some devices that are not used by the MD, if you will, the doctor, and that's great, but just be wary of how the depth of the actual microneedling, because depth's important. Up to about a millimeter depth will only get you so much more of the damage, and certain areas, around the eyes, for example, you can't go too deep because there's thin skin there. But around the chin, it gets really thick skin, and we want to maybe go to 2 millimeters. And so the devices used by most physicians and plastic surgeons allow us to go that. So just so you know, I'm going to talk about our protocol and how I do it. So we use topical numbing medicine, and very rarely will I need to actually do a nerve block, because the topical works pretty well and patients are fairly comfortable with it. I've not had a patient had me ever stop a procedure because of it or need anesthesia for it. So these are all office-based procedures and pretty quick. Let's look at the data. So facial scarring with microneedling and PRP. 50 patients, acne scarring, whole face was treated. One side of the face, they got the microneedling alone, and they just gave non-PRP. And the other side got PRP, so left and right. So the left side, as you saw, so if you look in the top slides over there, you'll see that with the PRP, things improved. And without, it did improve, because we know microneedling will work. We know that. We know PRP alone will work, but together, much better. And I firmly believe that. I think if you're going to do PRP, some patients come to me and they, and I get it. There's I'm going to do one, doc, and I will say, you're fine. Let's wait. If you had PRP, I want to do it again. No, wait. We got to get the results to come. And I think the combination is far better. So if you can wait, or financially you want to hold out and just get the best result, wait for that. Don't just try to do one and then later you're like, nah, I should have done both. I think the concept you need to know that adding both makes a difference. The idea of lasers, right? So if you get lasers, oftentimes with the PRP goes with the laser. These were forearms of patients, 2 spots, lasers done, one side got, and they both heal fine with the laser. But if you added the PRP, healing time was reduced. Our dermatologists at UCLA are the ones that I defer to and refer to all our patients for the lasers. They're the laser experts in our group. Some of our colleagues in Santa Barbara, Dr. Keller is a laser expert as well, and he'll get a lot of our patients for lasers. And so, but we work together. And I think if you're gonna do laser and you're okay with some of the downtime, but you wanna have really dramatic effect of the rejuvenation of the face and texture and contour, adding the PRP will be very beneficial. Here's a biopsy. So looking at a biopsy of the skin and seeing what's happened to the thickness. Thicker collagen on the PRP treated side, a month out. Not a day out, not 2 days out, waiting over time. And the references are here if anyone wants to look at the articles. So again, we're focusing on what works, right? So the last one is PRP with hyaluronic acid. So this is PRP and filler. Adding the filler, rejuvenating. The problem with this sometimes is I think it works well because you kind of get rid of the volume changes. So if you look at this patient here, for example, you'll see in this area, which is called the tear trough or nasojugal fold, over time, it's disappeared. Now, you may argue that, is it the filler that's lasting still? But I think over time, when you combine the two, the PRP affects the fine skin as well and it improves it. I don't combine it. Because I think for me, when I'm doing something, it has to be very focused and straightforward and not have a guessing game for each patient as to, well, the filler worked. Well, the PRP worked. Maybe they both work together. So I think in patients who want it, I stage it. I will do the PRP and microneedling, wait 6 weeks, see how things are going, and then do a filler on a separate visit if they want fillers. But the combination is very valid. Many do it, and it works. The literature shows it works. Okay, let's digress to hair restoration. Let's look at the evidence. So it works for hair. And so we'll talk about why. I think some of the benefits are obvious, but we'll talk about why it works, go to the science of it real quickly. It has to do with activating some dormant follicles. So if you have a bald area for a long time, I mean, no hair there, chances are it won't work. And if it does work, it's not going to grow significant hair. So if you've had a large area or a truly bare area, I will tell them try a hair transplant is a better option. It's important. The goal is patient care, optimizing what's going to work for the patient. Because let's say you do have some hair growth. It's not going to make the patients happy. It's not going to make you happy if it's not giving you what you want, which is hair that is not showing a bald area. However, thin areas where we have some hair, but we know it's lost, or you put your hands through your hair and it's thinner, you know it's less, you're self-conscious a little bit. And the most common scenario I hear from patients, and it's true, it's lighting. You're with friends and now you're conscious of lighting, not because of the necessarily some lines in your face, but you know that if there's a part line in the front of our hair, if that's where you're thinning, you're conscious of it. And I think those scenarios where we know if the light may not be there, you're okay, but you're knowing about it, something that's not surgery, not too involved, may benefit you. And I think those are the scenarios I think will help quite a bit. And importantly now, most recently, in female patients, because oftentimes even the term is wrong. We use the term male pattern baldness. I'll talk about that. That's actually an incorrect term. I think it's the same process, and it happens in everyone. It's just more classically in our male patients, it has a set pattern that's been classified, and there's science behind it. It's staged where we know. When we look at, I look at my own family members and myself, and where you lose hair, certain areas, and we know how it's going to progress. But in women, it may be diffuse. It may be a part line. It may be just thinner hair, less dense. Same concept, and I'll tell you my approach to it. Scalp hurts. So even though the slide's showing you draw your blood and you poke it through your scalp, if you ever bump your head somewhere, it hurts. Even if you kind of like you get a haircut and then you shampoo and then you kind of just rub a little bit too hard, it's sensitive. Scalp is very sensitive, lots of nerve endings. So many approaches, and I've actually evolved on trying to use my facial plastic surgery and facial reconstructive expertise to make it comfortable for you. So I do nerve blocks. Many people don't. Why? Because they may not know where the nerves are. But I don't want it to be uncomfortable. So some of the ways we try to do is we add ice, or we add a cooling machine to kind of make it cold, so when you actually get the needle point, it doesn't hurt as much. Topical numbing. It gets a little bit greasy and then you got to clean it off. So what we do is, for that one step, there's a couple of nerves right above our eyebrows, and if you know where they are and you effectively put just a 0.5 to 1 cc of numbing medicine, lidocaine, it will numb the entire forehead, the entire scalp, up to the vertex. It takes about 5 to 7 minutes for it to work. It's great. Patient leaves. They're numb here, felt like they went to the dentist, but it's not the dentist, it's on their forehead. And then about 4 or 5 hours, everything's great, and the pain's not there. So I think it's important. And I guess that's one other advantage where, yes, this is not really surgery, but having that expertise kind of helps in that scenario. So why consider it? This is really the main reason I got excited about it. Many of people in this room may have tried certain things. Rogaine, biotin, Propecia, they work. Definitely work. The problem is, you may worry. How long do I take this for? Forever. The moment you stop, you lose the hair dramatically. But it works, and you can be on it for long term. And I think you have to really take with caution, because anytime you look up something as a side effect or risk, it'll always be there. Even probably maybe in some simple things we take now may have risk that we look up on the internet, we'll find it. But there's been some controversies about Propecia and risk for prostate cancer. And I think the data is still equivocal. So don't be worried. I think it's a very safe drug, FDA approved. People use it, and it works. But again, it's a drug, it's in your system, and I think people worry about that. Rogaine, you have to apply it once to twice a day, and I think that becomes a compliance issue. The one thing I do urge you is that if you're going to consider hair transplant, PRP for hair, don't stop that treatment, because you will be really bummed about the PRP or the hair transplant when hair falls, and it's not because of this, but because you just stopped this medication. It has happened because people think, oh, I'm going to do this, now I can stop the pill. So if we're going to do that, we really need you to either continue with that or really be okay with the fact that you need to stop, wait for at least a few months to see the hair loss happen, and then we can start the process. But those are the main reasons. And there's no scars. So I think hair transplant surgery has really evolved. It's amazing. And I think in our group, Dr. Jeffrey Ronsley, Dr. Gregory Keller, I do it, not as much, but they really have become experts on it. In Beverly Hills here, some of the world's best hair transplant surgeons are there. And our dermatologists, really credit goes to them. I think the dermatologists, PRP, hair, they really are pioneers in a lot of these areas, and credit goes to them. And I think you should look into that as well, because really it's scarless a lot of times. But what people don't realize, and I think this goes back to the whole aging process, I'll digress for 1 second, it'll make the point. Someone comes to me for a facelift, they think they'll never get a facelift again. And I have to tell you, I wish I could have you stop aging, because if I get a facelift, now if I do it at 50 and you come back to me at 70, every part of you is 70, but maybe your face looks now 20 years less than you were at that time. Things keep aging. Hair loss, you get a hair transplant, the other hairs still drop as they're supposed to do. So 20 years from now, even our best hair transplant patients still have some hair loss. Fortunately, those areas that are more apparent have become less. And we see that a lot of Hollywood actors look amazing, and they've had hair transplants, and it lasts. So we know that. But truth be told, you will continue to lose the hair, and sometimes now adding maybe something that's your own blood, like PRP, may keep that at bay, kind of fight it. And so I think it's a good addition if you're thinking about hair transplant, but it's also a good substitution for it. Okay. So this is the proper term. So androgenetic alopecia. There's male pattern and female pattern. It affects both. And then there's spot hair loss. So we do know that indications for PRP in these two work. If you've had I've had patients come, they call, I've had a facelift, I lost hair, can I do PRP? I can't say it will work, or I can't say it won't. The evidence is not there. Tincture of time, we know the hair is going to grow back. Why does that happen? Sometimes when someone gets an incision in some parts of our scalp, it inflames the tissue. Remember that first slide? If you have inflammation, the hair follicles are very sensitive. They may drop. And so the hair doesn't grow, but it will grow, give it time. So for that, it won't work. And then spot hair loss is when it could be stress related, it could be multifactorial. There's some patients you'll see, and you may know some family members or maybe yourself, where you suddenly had a patch of hair loss that was extreme. It became a spot that was no hair at all. And it could have been a stressful time in your life. We do know that this will help in that area. And it will grow back, hopefully. But a lot of that may be multifactorial for that, but that's an indication for it. Okay, so the male or female pattern hair loss. I've put the slides, the next few slides, and it'll go to what I do at UCLA. Look, the words in red are important. These studies that have worked used PRP more than once. That's the key. Why I point this out is because when I started the PRP for hair, I waited. I wasn't going to do it because I wasn't going to be where patients come to me and I want to try it, doc. So I've had patients come to me and they don't get PRP because they want to try it. I won't do it because trying it, you will be unhappy. What I mean by trying it is, let's try it, come back in 6 weeks, maybe it works, we'll try it again, and we maybe did it at 7 weeks, but then it may have worked, it may not have worked. So this patient got 2 sessions, this patient got 1, this patient got 3, a week apart. So we looked at the data, and the data showed in all the literature, it's like 2 years out now, if you did it in a set pattern, multiple times at a distinct time frame, then you're really amping the growth of the hair and the hair cycle based on that earlier slide that showed what phases of the growth cycle of the hair it's activating and working. So again, this looks at the timeline. You can read that where, no side effects, patients follow for 2 years, hair density. So I found this, it's interesting, here's the good news. It's the one area where the evidence is going to be there for all of us to see. What I mean by that is, unless you come to me with a buzz cut to begin with, then it's going to be hard to prove if it worked because all your hairs are short. But most people come to me with long enough hair that if this is working and I take a photo of it and we look together, I take all the photos, I have you have your own copy of all the photos, and you'll sign a permission slip for it that it's documented, we don't publish it anywhere. You'll know if there's a long hair and then there's a short hair next to it, likely this is working. But I can't prove it otherwise if there's no little hairs growing in that area that it's working for you. So that's good, we get to see it together. The one part that it's been interesting is, and this is true, I just had a gentleman yesterday who, he had very little, and I'm the biggest skeptic. I'm gonna tell him I don't see much, but maybe there's a few, but there wasn't. But it was true. He was super happy because he puts his hand through his hair and it feels thicker. I don't bring it up. When you come to our office, and she's very open to tell you, my front office person had 2 sessions of it. Her part line is not only full, but her hair is much thicker. And her hairdresser told her, something's different. I don't know what you did, but what's going on? Your hair feels thicker. And so that's actually helped a lot. So we know the hair density does improve. Okay, another study. So 29-year-old hair loss, pre and post. Again, this is 3-month intervals and 3 sessions. And we'll talk about what I do for men versus women. Another study, dermatologic surgery, 25 patients. This is great because, it's hard to do, but I think in research terms, some people will allow you to split one side of the face and one side don't do something different, and then maybe for the scalp as well. But we're not experimenting. I think the data is out there enough where we're not going to decide on experimenting. You should get it for areas that you want and you and I agree to. And I work with what my patients want. And what I mean is, I may notice hair loss here and here, but it's what the patient prefers. Patient says, doc, I really want to focus on this area. To me, it's sensitive. I really want to get this area. If you have some PRP at the end, we'll put it back here, but really focus here, and vice versa. Some say, this is naturally going back. I don't want to have 2 areas and focus there. And others, I want the whole area. So we'll do that as well. So here's a close-up on density, not just the hair growth, but the actual hair itself becoming thicker. Again, same theme, right? So whether it was looking at papers that had 1 versus 2 versus 3, measurements taken at 6 months, important differences seen. Here's some of the pictures that people have published with PRP. this paper was good, a meta-analysis, and this is important. If you ever look up literature, like you Google now, and you can use Google Scholar, a lot of my patients do. They're like, Dr. Nabili, what do you look up? Or how do you look up papers? And what, do you just look at doctor's notes? And I go, no, we look at the literature. What does that mean? What is the literature? And so you can look up articles, and a lot of things are available. But meta-analyses, these are somewhat, they kind of are allowing you to quickly review things, meaning a paper looks at all the data and tries to take this person's 20 patients, that person's 10 patients, get all their data, combine their statistics, look at trends, and say, well, if we look at a lot of data, can we increase the number of patients and see trends in different directions and critique them? And it showed improvements with doing it. Now, here's a study I put on there that actually goes against everything I'm talking about. It didn't work. I know why it didn't work. You can't just do it once. Yes, there's papers out there, you do it once, it works. I just don't believe it enough. If I have 10 patients, I don't think all 10 will be happy with just one treatment. So I think that was probably something that, with that case, that was an issue. Okay, so we have a detailed protocol. What that means is it's not an experiment, it's not a study, but if you come to UCLA facial plastic surgery for male patients, recommendations 4. Usually the hair loss, testosterone level, the androgenic issues require more. Minimum 3, preferably 4. 1 month apart, you sign on for all of it. Women, 3. A couple of women have gone for 4, a couple have stopped at 2. That was okay, but they got at least, but I think now I've really tried to make it where, and people who come and say, I really don't know, I will definitely recommend others out there that would do it, maybe just a one time, but I really believe that if I'm gonna be behind it to really make sure you get the best result, I really wanna do something if I have to do it for you to really make it the best, and the only way to do it is the data shows multiple. The evidence shows that. A couple of patients, at the one on the right's at 3 treatments, the one on the left is after 2 treatments, and it's pretty remarkable, male and female patients, and it's continuing to improve. Now, mind you, the patient on the left, we didn't take temples, but at the second, actually right before the 3rd treatment, the hair was improving, and we kind of went off the protocol, which I wasn't happy about, but I get it, because patients get happy, and they see the results here, and they're like, well, my temples now, I think these, and so then we started another protocol on this side, so I went against it, but I get it. I mean, you get excited, your child's like playing with your hair and says, Dad, you have some hair growth there, and so it kind of acted, it's like, well, maybe I can get my temples. Now I'm thinking about it, so we added that there as well. Okay, let's quickly go through this spot hair loss. I'll just show you what that really looks like. This is basically at 3 months. This study looked at alopecia areata, which is spot losses, different process and improvements in the hair. Okay, 2 more sections, and I think we'll be open to questions. So this area I'm very excited about, but again, this talk is on evidence-based. Dr. Nabili, what can you really say the literature, the science, and people are showing it that it shows it may work and will give me the best benefit? Up until now, I can at least say with more confidence that a lot of things will work, and in my hands they will work. I am very confident that these things will improve and show it. It's just not there yet. It hasn't been tested and proven enough. So that first one is basically, this would be great. Would the PRP truly be the filler? I would love for it to be, because it's safer. It's a part of you. I inject it just like a filler, and it lasts. The reason I think it shows promise is you saw a couple of those slides where right in those little tear trough areas, they just had PRP, and it improved. It just didn't improve that first couple of weeks. The patient looked back at 3 months, 6 months, and it got better. But it's not going to give you that dramatic, that hollowing may be gone in everyone. So I think the jury's still out as to see if we can really just use it alone. However, a lot of those PRPs in those studies were low concentration. So my thought is that I think if we take what we know in hair and we apply it to the face, which means use the high concentration, why not? If we're going to put the platelets in, put the best you can. If it's good enough for the hair that's so sensitive, it should be good enough, if not better, for the face. So I think, so for me, when I do facial rejuvenation now, the protocol is high concentration. If there's some remaining at the end, the low, I'm not discarding it. It's facial rejuvenation. You'll get it topically with the microneedling, and we're not going to drop and lose 1 ounce of your PRP for that. But I think the high concentration will help. So fat injections. So let's just go to the data, and then last but not least is skin graft. I don't know if anyone's in the audience has had a skin graft, and we'll talk. It's one of the most simple yet most painful procedures we have to do, and whether we need to do it for reconstruction of certain parts of our bodies. But the healing in one paper shows it may show promise. Okay, so basically looking at rejuvenating the face with basically PRP and the fibrin matrix acting as a filler, improving the nasolabial folds. That's this area right here. But look at this slide. Also, the acne scars. The things that we can't, you can stretch the face, scars won't go away. They'll be stretched, and oftentimes if you have those lines, I always worry with a facelift, I may make those lines more obvious because naturally they're going in certain directions, and then by shifting the face, they look obvious because they're in the wrong direction now. So those are some of the issues I deal with, trying to deal with the fine lines in facial rejuvenation. I won't go into this too much, but this is Dr. Sclafani, really great facial plastic surgeon from New York. Focuses on making this PRP with something else as a filler to really rejuvenate the face. Adding that fibrin matrix. A lot of data, promising, and I think we just need to know more about it. Maybe adding high concentration with it now would be the way to do it. This is pretty dramatic as well. Adding the PRP for those areas around the eyes. Treatment of the nasolabial folds. Single PRP. This is amazing. So you're saying we just give the PRP. I just can't guarantee it would be the best result. I think for what patients want, and they want it to at least have some result, I think fillers are still the better solution for this. Now, mind you, if you Google my name and you go to videos, you'll see a similar talk as today's, because I know today's talk was really inspired because a lot of my patients said, I don't go on, the internet was fine, but I want to be in a live audience and interact and really modify it and fine tune it. But the other talk I have on there is on mid-face. And my philosophy on these lines is fill it with caution, because these lines happen because the face descends. So if you lift the face, the lines get less. If you fill the face and you keep filling the face, then the face doesn't look like it's supposed to be, and it's rounded and it looks heavy. Case in point, the best rejuvenation that is extremely unpopular is gaining weight. If you gain weight, you look more youthful. It's unfortunate, right? But it works. And the concept of fillers in some ways works that way. You look at, and sometimes you look at Hollywood and you'll see some people, you can tell they just look a little bit different. They look full. And I firmly believe that your natural beauty, we don't want to change that. So we want to have you, so if I ever do rejuvenation surgery on you, oftentimes the day of surgery or at least a week before, I really want you to bring pictures of 20 years ago, 10 years ago, 30 years ago, because I need to know how you looked. Because we're going to try to reverse the clock, and we know how things look. But if I see today some of those things don't look, maybe there's fillers there. And then lo and behold, we talk more about it. Yeah, I put some filler, I put a lot here, and so it comes into play. Okay, and then the last couple slides, fat grafts. So if you're going to get fat augmentation, this one study I thought it was promising, because if anyone's ever had fat removed from somewhere and they use it as a filler, it's great. It's part of you. It has some risk because it can be lumpy, bumpy. The fat can grow. But one of the big problems with fat injections, even though it's really good in expert hands, is up to 40% of it, and maybe even more, can disappear. Some would argue even 60 to 70, because it gets resorbed. Once it's out of the body and then brought back in, the body can take it, but a lot of it gets lost. So can maybe adding some of those growth factors keep it alive longer? So I think it's promising. No improvement. So these are people who have, if you added it, and if you're, for example, lipodystrophy, and this happens in people who are immunosuppressed, whether it's from HIV, some of the studies we're looking at, and it really didn't do much. So whether the PRP helped or not was questionable. And then last but not least is looking at donor sites. If you get a skin graft, it hurts a lot, and the PRP worked in this study. We're always trying to find something that will help for skin grafts and improvements. And then what doesn't work? And I encourage people to kind of do the studies or experiment with areas if they think it's going to work. So bleeding risk. When you do a facelift, one of the most worrisome complications and common complications is bleeding and getting a swollen area of blood called a hematoma. And the bruising. Can PRP help in that? I doubt it. Doesn't work. But they tried it. So why not? Let's try to see if we can minimize the bruising. This study looked into it. Minimal improvement. So bruising, arnica, eating grapefruits, I think all those things can help. For everything you think you may help, a lot of it may be just placebo as well. But we do think arnica does help for bruising. Fortunately, PRP doesn't really show much promise. Again, this is the data. I don't need to bore you, but there was no change in the rate of bleeding with using the PRP in that small study. Okay, in summary, we'll just briefly go through everything we talked about so I can open it to questions. So we do know it works in rejuvenating the face. I believe you should add it with some kind of trauma, whether it's a laser, microneedling, which is what we do. In hair restoration, we know it works. Do it multiple times. Whoever you see, and you're gonna go and maybe see other experts and get second and third opinions, but really make sure you remember that. You should try to get more than one session, okay? And then with a filler, we do show the evidence that it works. What might work by itself, maybe high concentration, which is my thought process, I think, and we'll see. Maybe a year from now, the patients that are now doing it with the system that I'm using in high concentration, we may get those results. And I may stop adding the microneedling for everyone, and maybe it'll be just by itself. We'll see. In fat, maybe, and the skin graft site, and then we know it doesn't work in the facelifts. So I'd like to thank you. I think it's been about an hour. Contact. So a couple things. This is important. UCLA is going through a big change, departments by departments, in improving and updating the websites to really optimize it for you. And so by next Friday, the Department of Head and Neck Surgery, and specifically the Division of Facial Plastic Surgery, will have a brand new website up and running. Right now, a lot of the areas are not active, and that's only because of the past couple of weeks. But I encourage you, because in that we'll have videos not only for PRP, mid-face rejuvenation. If you want to have a facelift, there'll be a video showing what facelifts are, how you do facelifts, rhinoplasty, nose jobs, as well as eyelid surgery and more. Feel free to email me. I think it's really important. I think part of UCLA and part of head and neck and facial plastic surgery is really patient-centered care. I think, you know, my patients, and I say it in the nicest way, they sometimes get tired of seeing me. I'll say why. Because I like to see you often. If you have surgery with me, you see me for a year. And what happens is, I don't want you to ever know that you're having surgery and that's it. So I see patients very often early on, and then it's every month for a year. And it's a standing appointment. But what happens is it gets canceled. Patients are busy. Dr. Nabili, I'm fine. I'll see you in 6 months. It's enough already. I'm okay. But I think it's important. And emailing me. Because I think you need to know that your team is there for you. It's not that I see you and then I don't see you, and I think that's the issue. I think you really need to make sure that whoever your surgeon is, and a lot of the stuff we're doing today and talking about, it's elective. Even more important. A lot of times I try to convince patients not to do stuff because it's elective. You don't need to do it. And really think about it and come back. And then you'll know. And I think those things, even more important, that your surgeon and your team, Lorena is the person you'll contact. And I have cards for Lorena as well as myself, but she really wanted me to make sure you have the email for her as well. Contact us. And next week, we'll also have an online request form, which will be even easier. Anywhere in the world you're at, you can just go on, you'll have a little security access, and you'll put in a question, and we'll respond to you within 24 hours. Okay? Thank you very much for this opportunity, and UCLA Health as well for letting me be here today. Thank you. Yes?
As you're going through this, I had this bit of a gruesome thought, but my platelets are old and tired. I have a 10-year-old grandson. why can't I draw his blood,
Yeah.
then spin it out and get it?
Yeah, good point. And I think you bring up an excellent question. Oh, sure. Sure. I think it was a very, very good question. And that is, as every year passes, our blood gets a little bit older. And it's a great question. And maybe our platelets, we would like more rejuvenated platelets. And he brought up the question of maybe my family member, son, grandson, who's younger, can I take their platelets? It's a good question. And I think I would love that idea. But here's the issue. The moment that platelet gets inside of you, right, I worry about even the slightest amount of inflammation. From the fact that even though you're type matched, right, is it possible that there's still some rejection that you don't see? We get blood transfusions, we get all those things, I totally get it. But I still think especially when it's elective and you don't need it, right, you really want to make it the safest possible scenario. I'll give you another scenario, at being part of the face transplant team, right? These are elective operations to reconstruct someone's entire face with a transplant. It's elective, but it affects quality of life. I think your point's very valid, and it does bring up the whole idea of quality of life and improving it. I firmly believe that your own platelets, unless you stop healing, are still better than risking adding something else from someone else, even though we think it's as close matched as possible. And the only reason I say that is in the microscopic level, and we're taking those platelets and amplifying them to a higher concentration, is it possible those growth factors could have some inflammatory in the highest dose that your body will reject? So it's risky, but I do think it's and it's interesting. In the lab, a lot of this stuff's exciting because platelets and stem cells, and it's really exciting times. And I think a lot of people are looking at nerve regeneration and looking at tissue regeneration, and some of that stuff will be from the platelets. So I think your point's really, I think it's in the future, but I think right now, don't do it. I would never do it. Yeah, thank you. Yes?
Use the microneedling with PRP?
I do. So her question was the microneedling with the PRP? Yes.
But how did microneedling, what does it do without the PRP, and how did it come about?
Yeah, so that's a good question. So if you like, let me try to go back a couple of slides. Her question was, what does microneedling do? How did it come about? I think the main thing is, have you heard of dermabrasion? I think a lot of people have heard of that, or microdermabrasion, or even we talk about laser, just trauma, or even a facial, a light peels, and people had peels done, and really causing damage to the surface of the skin. And so dermabrasion, we take a sander, you could even take sandpaper, and you glide it over the skin. We numb the area, I know. But what happens is you actually damage the first layers, as this slide will show. You'll damage it. But then as the body heals, the tissues get tighter, and all those subtle irregularities, whether it was acne scars or linear scars. So dermabrasion, I think you may look at it as, and this is important you bring this up, because the FDA is working on with microneedling, and we're trying to see if it is not dermabrasion. But the thought process is similar. So that's important. It's not dermabrasion. Dermabrasion is a sanding device, and FDA knows it. Microneedling is a separate concept, but it's causing the damage at those millimeter levels. The difference is, I feel it's safer, because with dermabrasion, there's two problems. One is, as you're sanding the skin, it's becoming aerated, aerosolized, if you will. And I think for the healthcare professional, maybe potentially a risk, particles in the air, but also it can go quickly deep. You can dermabrate pretty deep. And what happens with deep, if you look at this slide here, if we go through this layer, we're okay. If we go a little bit deeper, we get a little bit of bleeding. We want that. We go just slightly deeper, we get a little bit bleeding, and it starts to get less. Once it starts getting too less, and then you stop the bleeding and you start seeing some fat, that's permanent scarring. So it becomes this problem. And lasers have really, I think, I think you need to decide and see experts in both areas of whether they're doing laser or microneedling to see what's best. Here's the problem. The safer the instrument, the less damage it does, and you may need to repeat it. Case in point, if we did a peel, and I don't know if anyone's had a peel done, peels are great because literally you're causing enough damage to these layers with a chemical, and then over the next 7 to 10 days, it peels. But you can't really do a lot of things. You're red, it's, sore a little bit, it's starting to peel, you're moisturizing, you're out of commission for maybe 1 week if you're lucky, 2 weeks. Lasers, the more involved the laser is, sometimes if we do a surgery like a facelift, we'll add the laser around the mouth because we know the patient's going to be healing, not going out in public for a week or two. It's okay. Microneedling, 24 hours, you're out. Out to dinner, next day. Damage is there, the PRP went with it. So how it came about was acne scars. It worked, multiple sessions. The minimum is 4 weeks apart. Because I think the key is you have to wait for the healing. This is the one thing we want everything yesterday. And so I think the one problem is you gotta just wait and let it be. The damage from lasers, dermabrasion, peels, it will last you'll wait, and the results will be there. You gotta wait for the healing. You wait 1-2 years, no repeat. You wait. So, but the combination's more effective. If you're gonna consider the PRP, do this. Yes, question?
You mentioned you combine PRP, microneedling with PRP.
Yes.
Do you do that on the face as well as the scalp? And also, is there shedding involved?
Right. So good questions. Her questions were do I combine the microneedling with PRP? Yes, and I'll talk about that. For scalp as well as for hair, she asked, face versus scalp. So hair and scalp areas, it's just PRP, just high concentration. For the face, here's why. I don't want to run any kind of damage on those hair follicles because if you damage the surface, the hair follicle roots are further down, but we don't want to lose hair. Chances are those hair will grow, but we don't want to damage too many things above. For the face, here's how we do it. You'll look on the internet. Initially, when the microneedling and PRP was brought about, what people would do is the microneedling has friction. You can't just put it directly on your skin because it may skip and your skin is dry. You need some type of lubricant. So the thought was, as we see in this next slide, actually right here, these little microchannels was you pour the PRP on someone's face gently, that's your lubricant, and you run the needle on it, so as you're causing the little tiny damages, the platelets are going in. And very popular. Works. I think knowing from what I described to you, we want to improve down here. I feel we're not getting enough down there. And I feel it's a little bit messy. A lot of platelets on your face, needles, and so forth. So my method, and many people do this, is I inject, as you saw in those earlier slides. So we first inject the PRP throughout, especially the areas that you're worried about. But generally it's the whole face with a focus really around the eyes, around the nasolabial folds, this area, and right here around the mouth. Remember, facelift won't fix these fine lines, and we all know it. When you go like this, you pucker up, you see these, you don't like it, I hear it all the time, or you suddenly, it feels like, it's like kind of I don't like the term, but it's used a lot. Patients tell me it's like an orange peel here, this area, it's thick skin. So we do the PRP all around. Then I use the hyaluronic acid gel that comes with the kit for microneedling. It's a nice gel that has hyaluronic acid, and I use that as my lubricant, and I do the microneedling. And then if I have any of that low concentration left, remember, for the hair, we discard the low concentration. For the face, I'm not going to discard it. At that last part, we'll use a little bit of it on top, just a few cc's. And so it gets it from everywhere. You have low concentration on the surface, you have the damage on the surface, you have the high concentration going deep to really give you the best chance to rejuvenate the face. Yes?
Could you get rid of large pores on the nose?
Yeah, so it's good you asked that. I ask this question a lot of my dermatology experts. I think it's temporary. I'll tell you why. Her question was about large pores. Actually, one of my closest friends, a dermatologist in private practice, and he says if we could solve the pore issue, it'd be amazing. Because I think so many people ask that, right? And I think a lot of treatments help, but oftentimes you wonder, when you get out of the shower, pores are dilated, right? If you took a warm shower, and then 30 minutes later, your skin may look the best ever. Because everything kind of tightens up, and then it kind of relaxes. And if you've ever had radio frequency, you may know what that is, where they kind of just, it tightens your skin, whether it's from temperature or high frequency or ultrasound, it tightens your skin. It doesn't last a long time. So I think the pores reduce in size, but I cannot claim, even though you'll see it out there, that microneedling will eliminate or reduce it. I think it'll make them less apparent. I don't think you'll get rid of them. Yes, question.
How long does this last?
Good question. Right, so once we do, so my facial rejuvenation, she said, how long does this last? So for facial rejuvenation, I do it once, and then maybe no more for a year. Because I treat it just like fillers. Fillers go for about a year. Some go 18 months in certain parts of the face, and some go maybe 6 months, but on average about a year. However, some patients see some improvement, but they know they have a lot of age-related changes, and that's where we talk together. I say, I think we should consider another trial. And at 6 to 12 weeks, we'll do the second, but then we don't do any more. You have to wait. So I think the longest you'll last is probably 18 months. But here's the difference. I believe, based on how it's working, your age-related changes 18 months from now are less. What I mean by that is your skin has improved. Aging has happened, but the skin quality has improved. You saw that slide at 28 days. The thickness on the microscope level was better. Fillers disappear. So we have to put it in. But also some fillers, you may, if you've had filler, you'll realize, it's been I've been doing fillers for a couple of years and I need less now. But I know it disappears. Well, why is that? Because every time you put a filler in, you're activating some platelets. You're activating inflammation. The body doesn't necessarily say, well, what is this new thing you put here? I'm going to respond to it. My skin's going to get tighter. So I do think any of the things we do, it does improve. Botox, for example, we're not filling someone's face, but some people realize, I need less often. Because those muscles got weaker. You've done it for a while. Now, truth be told, a lot of people say, well, I've kind of become immune to the Botox and I have to use another one. No, I actually think the folds and those muscles, when they relax for so long, these lines, they get a time to have a break. And so if they're always not moving anymore, the skin can heal and those creases can be less apparent. Yeah. Yes, question.
With hair restoration, is it the same period of time or how long does that last?
Right, good question.
Finish the entire treatment? Or
Right, so I will tell you that one paper showed 2 years. I think in the colleagues that are doing it with me now, and my mentor, Dr. Keller, has been doing it, like I said, for at least 5 years. The longest you can quote to anyone, really, without a touch-up, is 2 years, but I think at 1 year, you're gonna need a touch-up. Yeah. So you say, okay, well, this is not great then, Dr. Nabili. I agree. So you're not gonna lose those hairs, but you're gonna lose hair that you're naturally losing, but you have to decide for yourself. Do I get a refresher or I do this 2 to 3 times every 1 to 2 years versus a pill every day versus Rogaine? But it's adding on itself. I'm still losing the hair that I've lost and I don't want to do a hair transplant. If the hair loss is significant, I recommend we do the hair transplant, whether it's with one of my colleagues or myself, and we add the PRP. Dr. Ronsley's adding PRP to his hair transplant. Dr. Keller adds it because why not? If we're going to put new hair in you, and it's expensive, as you all know, we want it to last. And we don't want those hairs to lose because some of those hairs, no matter even in the best hair transplant person, some of those hairs get lost because it's inflammation. The hair follicle says, sorry, I'm not going to take.
Well, with a woman, you don't necessarily want to transplant because that means you're removing from somewhere else. So you're really looking in terms of donors. Is that right?
Right, and so that's a good question. So you're exactly right. For women, I think this is maybe more popular and more pertinent for, that's a great point, for females with hair loss, because males have a pattern to the loss usually. You can see where it is, and for males, we know that if we take it from certain parts of the scalp, it's not going to get lost there. How do we know that? You can look at people who've lost hair over time. There's certain parts of their scalp that always has hair. That's a donor dominant area. In women, it is very similar, but maybe not, because the patches of areas that are thin may not be the same pattern, may be varied. So it's a little bit tricky, and so you're right. Maybe a less invasive approach every couple years may be more realistic. Yeah. Question back there. Yes.
I have two questions.
Yes.
What moisturizer do you recommend for your patients?
Mm-hmm.
Number one question. And number two, approximately how much do these procedures cost?
Right. So, okay, first question. Moisturizer, I don't have a preference. I do, and I think that you need to go to, and I do recommend actually, so I don't have allegiance, but there's some pretty amazing estheticians that are in Beverly Hills that, and I know and I recommend them. And also, oftentimes what works for you, and you've been doing it, I'm okay with. I don't have a specific rule. You're right. Some facial plastic surgeons you'll go to and they have their line. I will tell you that one thing, and this is Dr. Keller, and you can look him up on our website. He has something that's stem cell based as a moisturizer. It's called Definage, and I think that works, and that the dermatologists are really liking. There's evidence now behind that. But I don't want you to change your routine for it, But you're right. I think she brings up a really important point. When you go to someone for facial plastic surgery, you want it to be comprehensive. It can't just be, I'm only surgery, I only do facelifts. I don't know about moisturizers. But I will tell you where I'm limited. If I am not an expertise on it, I will definitely make sure you get connected to who's going to do it. Now, scars, for example, I use biocornium. Why is that? It's FDA approved. Silicone gel. It's called biocornium for scars. Not for the rest of your face, but it's FDA approved. It's silicone topical gel, and that will diminish your scars. But it has to be done twice a day for a minimum of 3 months. And it works. Why do we go into that? Because a lot of patients came in and Dr. Nabili, I tried this over the counter. It works great. They say Mederma. They do something. And I'm never going to, I think the one thing we should realize is, some of the homeopathic and stuff, you cannot say it doesn't work. I just can't tell a patient there's evidence behind it that I can stand by. Yeah. Oh, cost. That's right. Second part. Okay, good question. So prices vary, right? So call my office. We have a set rate. So it's very simple. The cost goes per tube. If you wanted to just say, I'm going to do facial rejuvenation, and it's a per tube. Here's the good news. I don't need more than one tube. In the old system, which was a smaller tube, right, and we need to do a lot, you need multiple blood draws. It gets pricey because you may need maybe 2 tubes if there's a lot of areas we need to inject. So for me, it's 1 tube. It's the price per tube. Lorena will give you all of that. For hair, it's discounted because if you're going to go for the protocol, it's discounted. If you combine it with microneedling for the face, it's discounted as well. Some patients come in and then let's say you have a skin cancer scar from years ago, got it repaired. This doc says, God, this little scar I have on my nose, but I don't need to do all this, Dr. Nabili. I just want to have this. And we could do just focused zones for microneedling at a very reduced rate just for that. And I think it's important. I think you should tailor it just to it shouldn't be, it's only all of this. But yeah, and I think we're not only competitive, but I think we're definitely, and my prices are UCLA prices, meaning dermatology, plastic surgery. What I want is for our UCLA family, it's one of us. It's not you're going to go to plastics and it's going to be less or more. So I really make sure that we're all the same price. And that goes also with our surgeries as well. We do definitely give discounts. And I think you should definitely, when you talk to Lorena, you should mention that you saw this and it was regarding this. And then consultation, by the way. When you see your doctor, you'll get a bill, it goes through the insurance. Sometimes those numbers are pretty, you're not paying it, but the billing is pretty high. You're like, wow, that's expensive, right? I think elective surgery, because it's elective, the consult fee should be minimal. And it should be free. What do I mean by that? If you're gonna do a procedure, my philosophy is your consult fee, if you did pay it, you went home, thought about it, came back, it's credited towards whatever you get done. Because I really think you're doing this electively, and there shouldn't be a cost to talk more about it if you're really gonna undergo something. And I think that's important as well, to really do your homework on that as well, and come back and talk again, and you know, if you're on the fence, don't commit the first time, just come talk, and then we'll discuss it again, and you'll be surprised that kind of gives you, empowering you again with the education's key.
I'm sorry, could you one more time show the slide that shows what the PRP does it do? I think it's at the end.
Oh, yes, the summary slides. Yes, of course. And like I said, they said this will be 6 to 8 weeks for it to come on. There's a shorter version of this on a webinar, and you can zip right through it too, but similar slides on this exact topic. Yeah, and I hope this kind of system with just kind of what works, and you want the one that does not work?
Yes.
Okay, no problem. Okay. And I won't use that, and if you get a face, we're not going to use it because it doesn't work, and I think our rate of blood collections and hematomas is less than 1%, and the reason is it's our surgical skills, and we don't. Our goal is, it's hard to absolutely guarantee it, but the real goal is we want you to go out, and I don't want people to know you've had anything done. That's the goal. I think that's really important. Mind you, I've had some patients kind of bummed with that too. I want them to know that I had a lift or something, but it's okay. Just say you change your hair color. If you look at that webinar on midface, you'll realize the goal of all of this truly is to accentuate this part of your face only. Everything I talked about, neck, here, hair, trust me, it's to get this back. What I mean by that is when we converse, and this goes back to our face transplant focus, our midface defines us. It identifies us. This triangle, our eyes and our nose and our mouth, defines us. Why we do facial rejuvenation, my philosophy behind it is, the things that happen outside of this draw us away from here. When you take a photo and you quickly see your neck that you don't like, that's where you're losing your eyes, because you're not seeing your eyes again because it's drawn to somewhere else. I lost some hair. I have these little things here. But as soon as we get rid of those, and how I know this is, the answers in my patients. They come back to me and they say, they don't know what I did, but they think my eyes are more apparent, or I'm sleeping better. Because that midface is more obvious to them. They look well rested. Yes, back there. You had a question? Yes.
I have actually two.
Sure.
Does that get rid of for the face, the PRP, does it get rid of the brown spots or 8 spots?
Yeah, that's good. So there are some papers now commenting on that. I think the microneedling does. And I think the PRP would only help.
And
So-
you're saying that there is no downtime on
24 hours is probably the best I've seen is 24. But you're looking at 48. If you bruise, let's say you bruise and you're at risk to bruise, I definitely think within 48 hours you're good to go.
And where do you draw the blood from? Like what part?
Yeah, so I try to avoid the wrists, even though we think that's a great area because we have a lot of veins there. They roll. So again, I draw. So first of all, I will bring this up again. If you come to facial plastic surgery, MDs do the procedure. I do it. I'm not going to have someone draw it. I draw the blood. Very comfortable with those veins there because we did transplants and tissues in this area, so we know the anatomy. But I just feel like you're going to get the best result of good quality blood there. That's high volume, good flow. And I have you get hydrated. I think that's important because you don't think about how much water you drink, and so I just think it's better to be hydrated. And then I'll give you all the instructions afterwards, but maybe I should just tell you now, downtime afterwards. So I want you, when you go home, you'll use an antibacterial soap just for 24 hours on your face, whether it's, whatever you usually use, but try to use an antibacterial just for 24 hours. For the PRP for the scalp, I want you to take if you take a warm bath, take a hot bath. If you take a cold shower, a warm shower. Why? Because the hot water is not only soothing, but it dilates the tissues and it makes the PRP really dissipate throughout the scalp. And I really think and patients tell me that When they touch their scalp, they'll feel lumps and bumps the first 12 hours because that's where the injections were, and it goes away. No bruising. Sometimes if we do it right here, because you've had it in your hairline used to be here and now it's back here, so I try to bring it more forward, you may get a little bit of swelling right in your forehead for about 24 hours. Very rare. Yes?
If you have a patient that was ill, they were on a medication regimen that caused weight gain, swelling of the face, stuff like that. Once they are off the medication, they're doing well, you do a facelift, you take out the slack skin.
Mm-hmm.
They have a relapse, they're back on the medication, they swell. Does that make it worse?
No, good question. Very good point. So you're exactly right. So let's also bring up, his question was, I think everyone may have heard you, but I'll repeat it just in case they're recording. If you're on medications and your faces gain weight or it's swollen and then you stop the medications and things relax. Another analogy to that is if you're going to get any rejuvenation, surgically especially, and you're on a weight loss regimen, lose the most weight you can. Because what I don't want is to pull and you're still, because what happens usually is when you do something, it has this, you feel good about yourself and it motivates you and it makes you kind of work out more. So I see a lot of patients who rejuvenate and now they come back to me and their goals were to lose 20 pounds. They did. We did our surgery. They lost 20 more pounds because this motivated them. They felt good, looked good, but then we have more lax skin. And so I worry about that. So then I always try to say, let's try to go for our target goals and let's hold off. I say, come back to me in 6 months. But you're right. So it's better to be at the most lax we can get you, the least amount of swelling. But really, that's another question. I will tell you this, and some would argue. Fortunately at UCLA, and why you use UCLA, we have really expert anesthesiologists. If you're not healthy enough to have your surgery done, and this is a little bit off the topic, but your question's valid, to do your surgery in our surgery center at UCLA, meaning it doesn't have to be at the main Ronald Reagan Hospital, which is for really complicated issues or health-related issues, then we shouldn't do the surgery. I believe that. I think the goals of surgery are to not alter your life in an unhealthy direction. And others may do it, but I think the good news about UCLA, their anesthesiologists are great. And if we worry about your heart, and this is a 5-hour procedure, maybe we need to not do it. Maybe we need to do clinic-based stuff, PRP, and kind of rejuvenate subtle things, maybe add a filler here and there to kind of get you to not only get rejuvenated, but not put you at risk. Yes, back there. Yes.
Does PRP address the same concerns that Botox would? And if not, then what would that look like?
Yeah, good question. So, very good question. She said, does PRP address some of the concerns that Botox addresses? It depends on the location. I say that because it's the end result. So the way Botox works, and why do we have wrinkles? That's the main question to kind of think about. Why do we have wrinkles? It's because we have muscles. And the muscles are in different orientations of our face, and the wrinkles form as I'm talking to you. I guarantee you saw lines here. You probably saw lines here because my animation activated those muscles, and it's been 43 years of activating it. And so then those lines form, right? And those bold lines, the Botox knocks it out, but the lines may persist, and you get frustrated because you're like, this looks great, but God, I really have these fine lines. So around here, for example, the Botox, these little fine lines, we call them crow's feet. The Botox works, it relaxes. The duration's only, in the best of patients, maybe 5 months, but most people 3 to 4 months. But then it doesn't, even when we do it here, you get those bigger lines away, but it's that fine line and texture that there's no muscle related to it because it's been pulling on tissues that have now become weak. And if you look at a child, for example, they have the same muscles, but their skin quality is so good that it hides. Nothing can wrinkle. It's as we age or we lose a lot of weight where things kind of show, right? So I think it's a combination. In the forehead area, it will knock out those big lines, for example. But skin irregularities within those, I think they're going to persist unless you do the PRP with or a peel or a laser or microneedling to get that out of the way. But the other point is there's certain parts of the face that everyone complains about that Botox won't work. So if we do nasal labials, people say, well, doc, why don't you get rid of these with Botox? Yeah, we can, but then your upper lip will droop, and that's a problem. Because then you walk around saying, well, God, did you have a... So I will say this, and it's unfortunate, but if you've ever seen someone who's had a facial paralysis, it's pretty... It's a sad problem, and I really think it's a very complicated problem, but their face, skin-wise, is pristine. The lines are gone. So when I evaluate someone for facial weakness, a separate issue, I look for those, even the tiniest hint of a line, knowing that the nerves are working to move those muscles. So I think in certain areas you can do the Botox in place of it and get improvement, especially when you're young. But as you get older, the combination will work, for sure. Yes?
For the hair, have you ever heard of microblading, micropigmentation?
Yeah.
What do you think of that?
I think it's all perception. What I mean by that is, and we're doing the microblades. It's interesting. I've had 2 patients now in the past 3 weeks call and say, do I do this? And I tell you, the results are amazing. And it's what she's talking about is you look at, and you can look this up, microblades, they do it for the eyebrows. It's almost like an artistic way of tattooing it, but in the direction of hairs, where it looks like hairs. Amazing, I will tell you. I don't know if MDs do it. I don't know. And I truly tell you that some things are better in people who are just doing it, whether it's an esthetician or not. I think it's perception. What I mean by that is it's what you're perceiving to the world, and if it hides it well for eyebrows, for example, it works great. The results look really good.
I'm thinking for the head.
Yeah. Here's the issue. I think that goes back to the latest and greatest. Maybe a couple years from now, I may talk about it, but I'm not going to do it. I won't do things that are the latest and greatest just because. I got to see it works, it lasts. But yeah, we do a lot of tattooing, for example, for scars, whether it's tattoo removals, and also for reconstructions, and I think that works. Yeah. A question right there. Yes, sorry.
Do the procedures that you talked about today, do they work for most people at any age, or is there sometimes you suggest a facelift instead?
Good point. Okay, so that's a very good question. So a lot of times when people come in, they may come in and they've seen either this talk or my other talk on doing this suture lift called InstaLift, which is an office-based mini facelift. And they're kind of bummed because they leave, both these patients and those, that I won't offer that procedure to them because we're not meeting the same expectations. For example, someone's neck laxity, this is not going to help. They have the fine lines, but they're really saying these folds are the issue and they're really deep. And they have what's called these jowls here. And this cannot be the reason for that. If they come to me and they've had a facelift and they still have these problems, then I say this is exactly why we're thinking about this, because I do the facelifts and I'm still not happy in this area. So the question is, I do deny a lot of patients, and yes, and my goal at UCLA is not it's not a business. It's not to say come in and let's do because you came in and we're going to do this because it's what we do and we want to make sure you don't leave us without having something done. No, I would much rather have you leave my office and be educated and realize, gosh, this didn't fit for me, and I don't want to do a facelift, but I probably need one, and I'm not going to go and spend the money and be bummed about it. So I'm going to tell you honestly about everything we do and what's going to fit for you. This is not a facelift, and it's a whole separate issue. This combats the areas where facelifts won't improve you on.
But you do the mini facelift.
I do a separate discussion, yeah. And this is FDA approved, and it's on, but it's millimeters. And so you have to come and see us or see the video. I have it on the webinar, UCLA Health, as well as if you Google it. And and it's interesting. I've had more patients come to me for that, and I would say probably 50% either went on to surgery left without anything done because they want to not do surgery. But I just did not want to do that because I don't want an unhappy patient to me in an elective procedure, knowingly that it's not going to give them the best result. Is just not right. Yes.
Did you mention mid-face?
Yes.
Did we see something?
No, you didn't, but I bring it up because if you're interested in the I talked about mid-face being the part of your body, or face rather, that recognizes you. And so all of the things we do, people will start recognizing your mid-face. Because usually a lot of the complaints that we have either come from things that detract us from the mid-face, or there are really problems in that mid-face area, the lower eyelids, around the nose, and around the lips, because we're conversing and seeing people in that scenario. I have a very, it's a nice slide we did. What we did was we took, and look up this mid-face thing, but we took 2 faces of very prominent people that you know, and we just switched the mid-face on the slides. Just a slide, just, PowerPoint. And you're looking at it, and we did this we do this as a exercise, and it's interesting. You know who it is, but you just are not sure because you're not looking at anything else on the outside. And then once we put the pictures back to where they were, you're like, oh my gosh, I exactly knew who that was. And you realize that point being is this area is really important. It's really important. And that's why when you look at photos, I think photos are the biggest problems, I think, that keep people interested in rejuvenation, because they look at photos and they know, I'm going to take a photo like this, or I'm going to take a photo like this, because you're sensitive to those areas that you see. And we know that because you look back at 30 years ago and you like that neckline, you love that neckline, and we want to get that back. And so I think photos are really important for us to kind of see how we've changed. Yeah. Yes?
For the neckline, you're just addressing, again, the fine lines, and it doesn't address any sagging issues, correct?
It's a good point. So I rarely will do PRP, and I don't do microneedling much at all, unless there's a scar there. But I rarely touch the neck with this procedures, because your point's exactly right. This area sags. You're not going to have, oftentimes people don't complain, I have fine little lines here. But it can be done, and it will be if you have a scar there, or the quality is just the turgor, the texture, that's all you care about. You have a good neckline, but the texture is bad. But the neck you have to be very conservative on, because if you go too deep on the microneedling, or you go too deep on the laser, the skin here is not as robust and not as thick as the skin here, and you can cause damage there. So we're very conservative on textural changes, because if you think about it, the neck, it's a lot of sagging, and this won't help. Yeah. Yes?
I think you probably answered this question, but I'm just wondering if PRP is always site-specific, because a lot of times when people suffer hair loss, they also lose eyelashes, eyebrows, other hair disappears. Does it make any difference if you have a PRP treatment?
Right, so that's a good question. So I will tell you that we need to make sure if you're losing hair, part of my actual questionnaire when I go through it with you, I need to make sure there's nothing else going on. No autoimmune problems. Even I'm not saying that those things are going to be contraindicated, but I want to get clearance from your doctor. Thyroid problems. If you had this history of this local infection in your scalp and the dermatologist thinks you're losing hair, maybe it's stress related, we don't know, I proceed with caution. Because you're right, what else is going on? And maybe it's not what we're doing. Or if you tell me I'm using Latisse for my eyelids and my eyelashes, and I want to now do something here, you're right. I will, when I go through the questioning, I really want it to be no other issues that are confounding it. And if there are, we'll talk about it, and I will talk with your primary doctor to make sure that this is something we can do safely. And if you have any bloodborne issues or hematologic issues, maybe the bets are off as to what growth factors and what's in there. We don't want to do that. Yeah. Yes?
That fractional CO2 laser,
Mhm.
did you say that you would do it with the PRP instead of the needling? Because I was told that the fractional laser is like a 20 downtown, and it's painful and it's all that.
Yeah, so that's a good point. So no. So let me tell you. So that's a good. You bring it up. So, and this goes off. I'll try to focus. Her question was about Fraxel, and you said fractionated laser. The terms get interchangeably used. In the laser, there's CO2 laser. That's a pinpoint that goes to one area and causes a lot of damage. Lots of downtime. Damage. PRP will improve healing in that downtime, make it less. But the damage from that's pure CO2 laser. That's one scenario. Fraxel or fractionated laser, the laser doesn't just go in one area, it goes in multiple areas, less intense, and the skin between those areas can heal. Less downtime, the PRP will still improve the healing with that. But then in the fractionated lasers, there's ablative and non-ablative. It's a whole separate spectrum. So you gotta be careful if you're gonna go to someone for laser, you know exactly what they're doing. If they're telling you 2 weeks, maybe it really is not a non-ablative Fraxel, it's ablative, and the PRP addition will just improve the healing. And remember, the damage on the surface on that last slide, we're injecting it and topically applying it, it will definitely improve. I think the combination of laser or microneedling both have the same result.
So then, if you do PRP, you have a choice between needling and...
Good, exactly right. Exactly right. Except if you wanted to do laser, I don't offer the laser with the PRP rather. My dermatologist will offer laser and we'll coordinate the PRP. And the question is, well, which one do I pick, doc? Well, that's a good point. So if we have sunspots, we have these little tiny red blood vessels, good question. If you have tiny blood vessels, some of our lasers work for that. And if we're gonna do laser, maybe laser is a better option than the microneedling. So I'd have you talk with our dermatologist and we come to a conclusion of what's best for you.
I want to thank the doctor for his great work.
My pleasure, thank you.